Good morning. It is Wednesday, April 30th, last day of April. And we are, I'm going to say, starting our committee work really on S-126. We have been taking testimony for weeks. Frankly, to be honest with you, we've been taking testimony since the beginning of this session. We have Ledge Council with us at 10, but in the meantime, before we have Ledge Council here, I wanted to kind of have committee discussion. And frankly, I really want to level set where we are. Because we've heard an awful lot. With the help of JFO's calculator, I did some calculation this morning. And I want to remind everyone of something. So I'm looking at Vermont Health Connect's rate sheet of all plans offered on the exchange. And currently in the year 2025, without an advanced premium tax credit from federal government, a family plan under a silver family plan every single month is $3,900. I think that we're all aware that starting next year, those advanced premium tax credits will be going away. They will be reverting to what they were under the Affordable Care Act, which only went up to 400% of the federal poverty level. So if we look over on our charts, 400%, let's say you make 401%, so I'm going to round up. A family of four makes $29,000 a year. Seems like a fine amount, doesn't it? 129. At $3,900 a month for a silver family plan, currently $47,000 a year. That brings that family's income down to roughly $80,000 a year. Nolan did a calculation. If you were to work a 40-hour week, that is $27 an hour.
Well, to 44 right now, it's $22.50.
$22.50 per hour you have to work and make just to pay for your health insurance.
That's cheap.
So we've had indications that Blue Cross Blue Shield will be coming in with their 2026 rates, which will be 20% higher than they are currently. And if the advanced premium tax credits go away, it will be upwards of about 8%, 9% more. I rounded down and went with 25%. If there's a 25% increase in premiums, that family that was paying $47,000 a year would now have to pay $58,000 a year. That's not doable.
That's what silver plan.
That's just for the silver plan. The silver plan, which by the way, has a max out of pocket for a family of $18,000. So let's say you have a hospitalization from one member of your family. Someone has an accident. Someone has even a minuscule health crisis that lands you into the hospital for even a day. You can add another $18,000 on top of that. That's not doable. That's where we are. We were sent S-126. I'm going to be really honest with you. There are parts of this bill that I really don't like. There are parts of this bill that I really do like. We were sent a framework. This is a bill that the intention was will be a medium-term plan and a long-term plan to get us out of the crisis that we are in. And no one is going to argue with me that we are not in a crisis. I think we've realized also that perhaps there are some short-term things that we need to do. Because somebody paying $4,800 a month, $4,900 a month for a family plan is not workable. I'm going to be honest with you. I don't have any grand design of how this bill is going to go. I'm going to start crying here. I don't even know where to start this. I want to tackle this one section at a time. I want everyone to come with their ideas. I don't have any big ideas. I have thoughts about where I want things to go, but my thoughts about that are no more important than any of yours. And I want everybody at the table, whether you agree with this bill as written as not, I need all of you, and I need all your thoughts, and I need all your ideas. And each and every one of us is going to walk out of here hating parts of this, but also loving other parts of it. And I'm asking you, please, to be open to not getting what you want, but getting us what we need and getting to a whole that will make it so that businesses will be able to offer health insurance to their employees next year. And so that people will be able to purchase health insurance on the exchange. And that hospitals will survive in some form. I don't know what that form will be, but I think it's very clear. I mean, I can send around, we have been sent the slide many times of the financial situation that most of our hospitals are in. It's going to be painful. It is not pretty, but something has to happen because we will not have a system of care in a year. So I really want to go around the room and I want people to tell me their thoughts on S-126, what they would like to see, if they have any ideas. We have printed out, each of us, all the suggestions from everybody that we have heard from the last 4 months. But ultimately, this might not be one of those consensus bills where everybody gets a compromise. Because I think we're beyond the point of compromising. I think that the 11 people that are sitting around this room need to make some tough decisions and get where we need to be. So I'd like to start and go around the room and hear everybody's thoughts on 126 and what they like, what they don't like, and if they frankly have any ideas of how we get to where we need to be. You want to start, Daisy?
I do. Can I clarify a question?
Yeah.
How we get to where we want to be in regards to the bill or the future of our healthcare system?
I think the future of our healthcare system. And what can we do in S-126 to help us get to where we need to be, while also addressing where we are? I'm sorry, Daisy.
I should probably pull up the bill in front of me before I start yapping away.
I was just thinking, could I ask a physical question?
Sure, of course.
This is just sort of following Lori's thought. Where do we need to be? and I sort of need to understand a little bit, as I think about sections, what the goal of need to be is.
Okay.
And I really appreciate how you introduced it, and because I've been kind of tearful all weekend as I went hard through the bill, trying to figure out where we need to be, and I'm not sure which sections get us where we need to be, because I don't know what we need to be is, given your framing.
Let's talk about where we need to be,
Yeah.
or where we all individually, let's just talk about where we think we need to be. Do you want to start with where you think we need to be, and where would you envision getting to?
I could start, well, obviously, the finances that you just described are untenable. How do we get to a financial, what is a financial limit that we feel we can live with? So that's an issue. I don't know. I mean, that's obviously untenable. So what is tenable is sort of a question, and how do we get there?
What's affordable?
What's affordable? I hate that. I'm like worn out on that word.
Yeah.
So I don't know what the right word is, but it's like, what can we do to support the 70,000 people that are being affected right now by what's going on? And what is acceptable to us as a committee of where we want, that we can say, yeah, I feel good about this. And I'm not sure where that is, but that's a question for me.
Can I throw something in there? You said 70,000 people?
Yeah.
It's not 70,000 people. Let's think about the fact that all these issues, they also affect all of the self-insured market, teachers, educators, health insurance, state employees, which means that it affects every single property owner in the state that pays property taxes. Frankly, every renter in this state that pays rent. So I'm sorry.
Fair point. We've heard a lot about sort of right locating, for want of a better term, of where people need to get care, where they should be getting care, right place, right time, right, whatever. And of course, that leads me to primary care, because that's, I think, what we need to strengthen. Right now, primary care, I think, is about 6% of our spend. Hospitals are 50% of our spend. How do we shift from the spend? Now, keeping in mind that part of the hospital spend is in primary care. So supporting hospitals that do support primary care, I think, is a good thing. But also the independent practices, just bolstering primary care. I get that it's a structural problem in our country and obviously our state, but those are my first two thoughts. Where do we need to be, and how do we support primary care? There are more, but I'll stop there.
Daisy, I'm gonna go back to Daisy.
I think we could go a lot of directions with where do we want to be, because we've been hearing about so many problems for the last few months around the table, but I really want to focus my input around section 1 of the bill, which outlines the purpose and goals that this bill came to us with. Especially around health outcomes, quality, and access. So I think if we focus on that, and with many of us coming from different regions, I think we'll have some balanced input and different opinions, of course, on how those things can happen. And I also am going to try, as we have discussion on this, put aside my own opinions of what we need and really listen to the folks in these stacks of paper, because those are the experts. And that's what we do, is we translate their input into legislation. And we have had some incredible testimony over the last few months about this bill. And I think we need to listen to what the folks on the ground are telling us they need. I mean, we've had Green Mountain Care Board say, take this off our plate, take that off our plate. And, they want to build capacity to have greater oversight and more partnership with the Office of the Healthcare Advocate. And I think there's just some really wonderful compromises in this bill that I support. I think the most important thing for me is improving the quality. That's something that healthcare reform in Vermont really needs to strive for. We focused on affordability for a long time, and I'm really ready to see some focus on quality for our patients. And I think the VPQHC language that they submitted is wonderful. And I know that's mostly for sections 8. And so we'll talk about it later, but I think that's one of the most impressive input and impactful toward meeting the goals and purpose of this bill. I'll leave it at that for now.
Okay. Lori.
I view this in 2 ways, and I have suggestions for some of the sections, which I'm sure we'll do when we go through them. This is a continuation of work that this state has been doing for a very long time. And while I don't like some of it, I do like some of it. To me, this isn't going to get us to where we need to get to in the short time. And I think what's lacking is the ability for the focus of the system as a whole. I thought it was really interesting during our joint hearing last week when someone brought up system. I think it was Tom Frank from North Country who said, he was sitting, so I don't know if everyone heard it, he wasn't at the witness table, that we're not a system. And it's true, we're not. But yet you close beds at CVMC, it's going to affect a hospital over here. And we're not looking at that. And so I would like for us to put in here, and I do have language that we'll share at an appropriate time, that we require AHS to begin actually really looking at this as a system and making the changes accordingly. This is all good and it's needed, and we'll get to, a point with your leadership. But I think it is missing an immediate action that we need.
I agree. I was I was struck by our joint hearing
Yeah.
of there's no plan.
There's no urgency.
There's no urgency.
Well, except from Just Homes, I thought there was.
Well, right, but the people who are, the transformation work is being done at AHS. There is no urgency.
And we, under your leadership and
And the whole committee.
the whole committee, I mean, I remember Act 167. I remember where you were sitting and, that set this in motion. And you're right. I mean, accountability of, we've set this in motion. Where are we going and why aren't we getting there? And what do we need to do to get there now? Albert, do you have thoughts about?
Sure, I have thoughts. I, from all of the testimony, from what I know, from what I've been involved with over the years, absolutely right. What we're doing is not working. It's costing too much money. Quality of the care is not where it should be. I have big ideas, but those big ideas, I don't think we can afford it in the state. But one idea that I think we can afford is to pick out a piece of the healthcare system and really work on making sure that that part of the system, and let's pick primary care as an example, that part of the system is working well. People are being taken care of. People are not going to the emergency room for minor things, and that will help reduce the cost. But we have to set up that primary care system so that it can be adapted statewide. My recommendation would be that we have and it's in here somewhere, a model that we start off with of how primary care is delivered and build on that build on the primary care to the plan for the entire system so that it doesn't cost 4,000 something dollars a month for people to get insurance. I think the state of Vermont itself has to look at financing. I think we have to make investments in that area to be able to do that. And that's going to be a big nut to chew. But I think it needs to be done. My preference would have been to start off with the hospital because it's the most expensive part. But I think building from the bottom up, it's going to give a good foundation. And then when we get to the hospital, their costs will already be down because the primary care system is working well, the way it should. And I look at going to places like the FQHC, the express care places, that's where the primary care takes place. But the state of Vermont is going to have to make an investment, and that means everybody. So that's for starters for me.
Thank you. Wendy, I'm gonna put everybody on the spot.
Okay, well, I think that's a great idea, but I think that's gonna take too long.
No, we're gonna be in charge of how long. This thing of 29 and 28 and all that, I missed that in my little, those times, we've got to do it sooner. I don't want to create a whole system. What I want to do is use the system that's already in place.
Mhm.
We have a system of primary care that is fractured, it's fragmented. What I'm saying is organize it and do it right away. Why do we have to wait till 2029 to do that?
That's the one thing that I didn't like about that bill. It just seems like everything is stymied. Like, I feel like,
Well,
to me, we're at an inflection piece right now that I just feel like we should get everybody on board. I think, and in my opinion, no one's gonna like this, but I think Fletcher Allen has become like Fletcher Allen, oh my God. Has become almost like this monster that we're all beholding to this one place that we're all like, and everybody else is beholding to them. And I just feel like they need to play nice right now. Like they were talking about how they can't move people out of their facility. Well, let's make that available to them. Let's figure out how we can move people out of Fletcher Allen by having them play nice with the other hospitals right now and like figure out like who is more critical, how you can like push out the care that's needed in this place. And I agree. Primary care is where we need to focus our money and everything. But I think there's a culture here that even I, as a consumer in primary care, have always been like, oh, you need to go see your dermatologist for this, and you need to go back to your dermatologist. I still see an OBGYN. Why? I'm never gonna have another baby in my life, but you do you do see like specialists, and it's because of the culture that we have. I could just see my primary care for the rest of my life and never have to go into a hospital for anything else except, I get my boobs squeezed every once in a while.
I love committee discussion.
I know. But it's the culture that we have built up in healthcare right now that needs to be changed. And we can address that at some point. But right now we're at such an inflection point that I just feel like we need to have everybody on board to like say, let's like have a couple of years just to right this ship that we're at right now. And then.
well, if we do primary care, we're also going to do prevention because that's where it's going to take place. The cultural change is going to take place there.
Yeah.
It's not going to take place in the hospital where everybody's going.
But that's what we've built right now.
and we gotta change that.
I know. How do we do that right
Gotta do it
now?
quick.
I think
It's
what,
costing too much money.
I think what you're saying really iterates what Lori was saying is that it's a whole system
Mm-hmm.
and the system isn't working or the pieces that should be a one and a whole are not working together. I was thinking about some of the testimony we took last week from, I can't remember which hospital it was, but they said, we have empty beds. We're willing to take. And they would call and they'd be like, no, you can't. And then the same facility is saying, we don't have beds.
Exactly.
Well, I think this kind of is veering toward the purpose of the data sharing, right? And
Yeah.
that piece of the bill, I think, is incredibly important. And it's good that it's in there, although I think it's so complex. And then we're also taking up 63?
63.
Yeah, 63. That I think is another, I won't go there, but it's complicated to me, all that, the data pieces, but I think they get at some of the coordination and being able to facilitate the system monitoring and communication.
I just thought, yeah, I see 63 is essentially bringing up the Green Mountain Care Board to do the actual work that they need to do.
Yeah.
And because we've given them limited resources, and they need to use their resources to the best of their ability. And the things in S63, that those are not to the best of their ability.
Mhm.
Woody?
I would disagree with that.
Okay.
I
About
do not
63.
care for the Green Mountain Care Board. I'll tell you that right now. I think this bill gives too much authority, but I'm going off what I want to say. I think it's important that we try to maintain our healthcare system in Vermont, whatever we do. People have to have access to healthcare. And I think that's very important. We need to keep people healthy. And as everyone has said, primary care is an important part of that. I think these bills focus on too much. I think we should be focusing on reference-based pricing and global budgets, and that should be our attention. And as these bills are written, I don't think it's going to correct our situation.
Well,
That's
good
all I
news,
have.
we get to rewrite these bills.
And I'll just say, I think the hospitals are trying their level best. I'm not talking about UVM Health. I'm talking about, our rural hospitals are doing their best to consolidate services, working with other hospitals. But that will not be enough to correct our situation that we find ourselves in. And don't forget, this has not happened overnight. It's taken years. And I think we all have responsibility for this, not just the Green Mountain Care Board, but this legislature or our legislature, and perhaps the entire health system, as well as the Agency of Human Services as well. We all have contributed to the mess that we're in. And maybe even Blue Cross Blue Shield as well. I've said enough.
Mari?
Great conversation. I agree that we need to create one system. We need to take bold action sooner rather than later. I'm also concerned, just want to keep in mind as we shift towards primary care, and do believe that we need primary care providers with teeth leading that change. We also have to keep in mind that this will impact healthcare professionals that work in hospitals. We're already seeing the impact of staff having to go elsewhere. And I'm not just talking about myself, but a lot of other workers who won't be able to find work in the hospitals. I know we don't, I don't know where we're going to get the money. It's going to take an investment to make any bold step towards a more unified system that's actually a system. But I do think we need to think about that as how, if we're going to make that change, and if we're going to make a bold change sooner rather than later, how are we going to pay for it without adding more financial burden to Vermonters? We can't do that. That's it.
Great, thank you. Alan,
Okay. I agreed with what he was talking about as far as what we were doing at the end here, but first of all, I want to say I'm disappointed. And this is where I'm talking about we've created this mess, everyone, and we won't point fingers, but I'm disappointed that it's taken to now to realize we're sitting on the edge of a cliff. Okay, what the heck have we been doing? Okay, have we not made the tough choices that was necessary? Are we getting all people, all players involved, communicate? Have we discussed this with the primary care providers, the hospitals, insurance companies, everyone? It doesn't, all of a sudden we're saying Green Mountain Care Board is going to do this, we're going to do this, we're going to do this. Have we been communicating reference-based pricing, for instance? Have we talked to them about, are the hospitals on board with this? How much communications have we had? So that's discouraging to me, because nothing in this bill, to me, and I'm not the brightest fellow there is not going to help this immediate crisis. Long-term, probably. Okay, so we're in a crisis, and that's all we hear. And what does the Green Mountain Care Board, the Health Advocate, the AHS, Vermont Association, what are they? They're giving their ideas, but what have they been doing? So that's disappointing to me. And I think I don't know how we're going to get out of this. So I don't think anything in this bill is going to help us immediately.
How about, go ahead.
oh, I wanted to ask Lori if she would level set us and give us some history
On how we're here.
on what we've done in the previous 6 years.
God.
Or 8 years.
When we knew this was happening and the things that we've set in place that still have not come to fruition.
Yeah, I mean, one, I think this is the Titanic that we are trying to turn, right? So it's very similar to the conversations on education. We have this large system, right? We have a lot of people that are employed in the system. We have a lot of communities that rely on the system, right, to keep their vitality going. So it's not just what have we not done or done. You got to look at the whole picture. I think we can place blame on every single entity. I don't want to go there. I think we need to move on from that, but I agree with you, every single entity, including the folks at this table. But I also think it has happened quicker than we were paying attention to, right? So you had the pandemic, we had some sustainability issues. We were starting to look at Green Mountain Care Board required in 2018 or 19, I think it was, for hospitals to start doing sustainability work. That got stopped because of the pandemic. That caused a lot of problems. And now, here we are. We've tried to focus on primary care. We did the Great Bill last year to support primary care. We have put reimbursement rates in where that wasn't put in by the administration to keep primary care and mental health going. But I will say, I think until there's a crisis, people don't necessarily react to the full capability that we could react because we're not yet in a crisis. That wasn't a lot of history, it's more my opinion, but,
Yeah.
but
Yeah, I think, first of all, we did see a crisis coming. I think things were in place. You, Alan, weren't here during the pandemic, but everything we've been working on sort of stopped at the moment that the pandemic hit. And it was sustaining, frankly, it was sustaining life.
yeah,
And that was years. Also, a lot of federal funding came in, which kind of masked the problem. And then when that federal funding went away, it was, oh, now look where we are. And what we saw as a coming iceberg, we got distracted with good distractions. A pandemic was a good distraction. But, now I think we've hit the iceberg.
if I can just add one thing. So we have to remember, it was 2022 that we passed Act 167. So that was before us, right? This year with the result. And it's accurate, except for the timeline. It's a lot quicker, happening quicker than what Oliver Wyman put in the study. But so we have been thinking about what we need to do. Now we need to make some decisions that, people that sit around us in this room are not going to like.
I guess one question. I haven't heard anybody say when we're gonna get the money. If we're $200 million short, we all know that because we've been told that every day.
Can I clarify that?
Okay,
We need to reduce spending by $200 million in order to get to a doable insurance rate increase. So I want to be clear on how people are talking, because I hear people in the street saying, we need to find $200 million. They're right, like, that's what we're trying to get to. It's not like if we don't find $200 million, everything's going to collapse. Just means that people are gonna have to pay a lot more, which is not sustainable. But I just want to be clear on that. But go ahead. Sorry. I didn't mean to interrupt you.
but that's it. But the question isn't how we need it, where we need it, when we need it. It's how we're gonna get it. And I don't see anything in this bill that's gonna help that short term.
Rafa, did you want to add something too?
No, I don't think so. I've been dealing with this for a long while. And, I see things that were in, 167 that kind of put us on the path to do certain things. I don't think we did them. We were planning to do it. And that's on us. In terms of money, you're gonna have to make, in order to fix this thing, an investment's gonna have to be made. Now, where that investment comes from, I don't know. But you're gonna pay one way or the other. You're gonna pay 25% on increases in insurance premiums. We're gonna pay for it, one way or the other. So we better figure out a way, we better make some decisions on what we want to do to build this system. And we've got all kinds of testimony, we've got written stuff. We ought to be able to figure this out, do something short-term that's going to lead into the overall picture. That's the entire healthcare system. And that's what I'm looking forward to, building, as I said, building from the bottom, putting a good foundation in. And it'll take a while to do the whole system, but at least let's get started. Let's do something that's positive, that's going to start controlling the price of healthcare.
Or what you just said really reminds me one of the real fundamental things, I think, Penny, that goes with your point about what have we been doing. One critical thing we haven't been doing is a lot of collaboration. And I'm talking about the executive branch and the legislative. I will tell you that, you know, when Lori was going over the history, there were a lot of staffing changes and shortages during COVID, right? Both in the system of care, but also in the administration. People would get burnt out and people wouldn't, you know, were leaving their jobs and the administration wasn't filling those seats. It was difficult to, right? And so we had a lot of positions that were managing some of these health programs were vacant. And so I think, you know, things really did get put on hold. And I think as long as we are willing to partner and have shared goals with AHS, I think it's a good sign. And I think I've seen good promising signs of partnership and willingness. And to Lori's point of sometimes it has to get to a crisis. I very much agree with that, but I'm hopeful.
Brian,
I'm glad I got to go near the end. I got to organize my thoughts and listen. So I'll try to. No, I did not use AI for this one. I could enter this in right now and see what it says. So since I like the way that you framed the discussion, because I feel like I'm free to be philosophical and not just be so hyper focused on language and a bill. So I'm gonna talk about the big picture and kind of go all over the place, but it'll make sense. So I don't know the exact year the policy change occurred. I know it was after World War II that it escalated. It probably was World War II because it was, I believe, anyway, deinstitutionalization was a policy change in US history. After World War II, veterans organized because they were being put in quote unquote insane asylums, and they organized to around it's what Westview House is called, the Clubhouse model, creating these peer-run, community-based services to take care of each other out of hospitals. And between the 40s and the 60s, deinstitutionalization played out. We had the Community Mental Health Act I think it was called in 61 with Kennedy. And the United States was talking about building out this system of care and to replace asylums and poor farms and boarding schools and training schools. And we never did it. And the impact of disinvestment and dismantle, it's sort of like starting a building and then just leaving it. So it's not really dismantling it. It's more like not finishing what you started. That when you build something and you don't finish it, then it decays, it falls apart. If you don't do your deferred maintenance, things fall apart. And I think that's what's happened here is people were dumped out of institutions, not that they were the best thing, into the community without a system in place to properly take care of people. And from the 60s to now, that's like 60 years, we see the long-term population health impacts of that. And despite all the advances in medicine, not everyone has access to that. And even when you do, a lot of American illnesses could be prevented if our lifestyles were different. So ultimately, what we spend money on is what we're going to get. Like you get what you pay for. So we've chosen to spend money on the higher level, the more expensive care, big fancy hospitals, et cetera, and neglected our primary care practices and our sort of smaller providers. And then we see the result. Also, we've made it, we designed a system where the cost is connected, making a profit off of sickness. So then we see something like during COVID, pharmaceutical companies taking massive amounts of government money to make vaccines. And then as soon as they can, they're charging you $1,000 for the COVID medication, you know? And I went through that personally. So I use that as an example, how disappointing it was. So where did all that money go? So I just think that there's only so much we can do about the bigger picture because in terms of national, international, but we can definitely do something to improve, to bend the curve. And I just want to present one example of something Vermont has done that I think we can learn from, called justice reinvestment. So incarceration is expensive. I can share more information about that later if you want to prove it. It's expensive and it worsens health outcomes. And Vermont decided to start reinvesting a small amount of our corrections budget into community-based services, and we definitely haven't done it enough. And then there was Justice Reinvestment 2. I think we're ready for Justice Reinvestment 3. But I was thinking about this recently about how we spend 100 and something million every 3 years on a healthcare contractor in corrections. What if we took that 100 and something million and we invested into the system of care and just had those providers work in facilities? Like, that's a very simple solution to me. As an example of that, we could learn from Justice Reinvestment and do the same thing in the. So, for example, we have primary care offices struggling to stay open. We could create a network of, like we're hearing, centers of excellence, like the hub and spoke model we have in Vermont, surrounded by primary care clinics, but that system of care can serve people wherever you are. If you're homebound, there's a way the system of care can reach you there using telehealth or home visits. If you're in a hospital, maybe community-based providers can, like a therapist, can go see their client in the emergency room. That's not even allowed. You can't bill to go see your client in the emergency room. Like, there's this fragmented system of care. And then furthermore, when a person ends up in a correctional facility or on house arrest or in some situation where there's justice involved, instead of them losing access to healthcare and be locked in a cage, even if they're in a cage, the healthcare provider should be serving them in the correctional facilities. Like, we could reinvest spending in the healthcare system from these larger institutions that are expensive, like hospitals. We can control the cost. To speaking to someone said, over here, I don't remember who said it, something about where's the money going to come from? I think the money comes from setting caps on the cost at the hospitals and reinvesting into the community-based services. And then over time, if we do this right, we may have to lose some things, but we can use we can find 100 and something million from corrections. We find 100 something million from hospitals. We can piece it together, but we're going to ultimately have to make fundamental change. Someone said, how do we get to this place? I've only been here 8 years and I refuse to take responsibility for all of this. But I think the problem is we cut corners. We're always like, we're just going to do this little thing because we don't want to mess things up. We're just going to do this little thing, or we're going to study this thing. And then we can't do that. We're going to study this thing. We can't do that. And I think we can't, we have to just, like the chair said at the beginning, we have to just do it. We can't no longer put this off. We need to do the change now. And I think 4 years is too long. It has to be quicker. And I'll end with this.
Okay.
The last thing, this is what I'm going to end with. This is the thing I want to end with. Does everyone know what a blue zone is?
Mediterranean diet thing?
It's like that. So blue zones are places on Earth where people are really healthy. And it would be good to take some testimony on that at some point, because I think we can make Vermont a blue zone. If we reinvest from hospitals into primary care, or if we reinvest from prisons into community facilities for wellness. Like, imagine if every part of Vermont had public access to wellness facilities, and everyone doesn't have to go to the gym, and everyone doesn't have to go in the pool, everyone doesn't have to go to yoga classes, but we should be offering all of the things that we know that make people healthy for free as part of this primary care. And people might say, well, nothing's free. It's true, but this investing in population health, we'll just see, sadly, those of us at the table may only see a fragment of that, but in 60 years, people in Vermont will be in a very different place.
Thank you, Brian.
All right. Thank you for hearing me out. I tried to not go off too much, but.
Very interesting.
So I heard a lot of themes. Primary care, I heard as themes. I heard moving faster. I also heard don't move at all.
I have some comments too.
Oh, I'm sorry, Mari. I thought you had made your comments, but go ahead if you.
Thanks. I have more thoughts.
Okay.
We all know the system is fragmented. It's a leaderless system in that, because in the United States, healthcare is driven by money. every entity in Vermont has been making very rational decisions to go, I don't mean this in a as badly as it sounds, but to go after the money, to follow the money, to make sure that their entity can survive and thrive. And these entities are full of good people doing really good work. And the entities are making very rational decisions that have contributed greatly to the moment that we're in now. And when I mentioned a unified system earlier, what I forgot to mention is that I strongly believe that we need one entity with unambiguous authority to be leading this change. And in collaboration with the legislature, in collaboration with all of the stakeholders, but we need one leader, not 14 or more. And to me, that's the Green Mountain Care Board. I also think that AHS plays a role, but I'm going to be frank that AHS is full of good people also doing really good work. And we did not hear anything from the executive branch, from our governor this year in the state address, his address to the legislature. We didn't hear anything about healthcare. So I am concerned about whether we do have a strong partner in the executive branch, which is another reason that, and I do think that AHS does need to be involved, but I do have a concern about the reliability of a partnership at this moment. So to what degree we craft legislation that requires things of the executive branch, the administration, I think we need to be very clear about what we expect and have ways of measuring and effectiveness and holding state government accountable to what we put in motion.
Thank you very much for that, Mari. I've been looking at the bill and I keep thinking too many mays and not enough shalls.
Leslie, if you're ready to go onward, or
Yeah, I was gonna bring Jen up, but keep going if.
well, I was really intrigued by what Woody said about reference-based pricing and global budgets. And I'm thinking that if we focus on three things, that those two and primary care, and shifting from the expensive sites, hospital sites, which is what I said earlier, which is 50% of our spend, to primary care, which I would love to make 20% of our spend. It's now 6%. And I would love to have a goal in there, either in the statewide plan or in that section of our goal of what the primary care spend should be, including the hospital-based practices, as I also said. I think that those kinds of focuses with looking at more realistic dates are something that I would like to talk about more. I just read over the Vermont Legal Aid presentation, and I think there's a lot of important stuff there that I think we need to think about and include to help us focus, because I think that's what it helped me focus where we need to go. But once again, you started with your introduction, which is, important, really important. How do we what are we willing to accept for Vermonters as what they will be paying insurance? Because of course we know what's going to happen is no one's going to buy it. And then we're going to have people who are sicker, who are then going to cost more. It's a downward spiral. So how do we do this by the next budget season, which starts in July for the Green Mountain or August or whatever it is. I guess the insurances are in July and then the hospitals are in August. So we have to have something that goes into place July 1st that affects the next hospital budget season at the remember. And that's what I'm hoping for, as Woody talked about, move the dates, reference-based price, global budgets, primary care spend. Still medium and long term, I get it. I'm waiting to hear what the short term worry, how we're gonna address that. That I think is in a separate location at the moment. So I would like to focus in on three things, I think is what I'm distilling down to.
I'm sorry, I didn't mean to interrupt. What do you mean by that last little statement you made?
Which part about budgets?
The very end of what you were talking about, I couldn't hear what you,
Well, I think if this is what you're thinking, I feel like we need to have it ready to go by July 1st. Because the hospital budget season starts in August. And we have to have our systems in place. Yes, of course, it's obviously not a system. And Woody and I had a conversation yesterday. What his community needs is really different from the southeastern part of the state. And we need to be able to allow someone with authority, and who said that, who's in charge. So
I think that was a recurring theme among.
I think Tom, you were saying who's in charge. And just establish in statute, and for now anyway, because that's how statute works, who's in charge. And be able to start working on real things.
Isn't the short term addressing the 200 million shortfall?
Well, that's not our job.
But isn't that the short term?
Yeah. But it's not in this bill.
Neither is reference-based pricing and global budgets.
Yes, it is.
I mean, we're opening up,
Yeah, that's in this bill.
That's in this bill.
but we're opening up the bill. I mean, you can add any language that you want. So I was just asking, is that the short term?
I don't have language about the short term because I've heard that other people are talking about.
Okay, so thanks, everybody. I guess maybe I should say what I would like to see.
Yes.
Do I get it?
I was just gonna say, it
Just
might be a
my
good
opinion
idea.
It does. So I think 4 things I would like to see. And I don't know how we get to it. As I'm looking over here. Here's what I want to see, Jen. I would like to see us get to reference-based pricing as soon as practical. I would like to see reference-based pricing used as the method to allocate the resources in the places where the resources are needed and required. The right place, the right time for the right price. I would like to be able to use reference-based pricing to reset and recalibrate the system of care all at the same time where there is an actual system of care being developed. And once the system is right-sized, I would like to see hospitals transition to global payment. But I think that will take years to get to. And I think that services and hospitals need to be right-sized for their communities so that their communities are receiving the care that they need, care that they deserve in the setting that we can afford. And I think reference-based pricing is a way to get there. And I think it needs to be done as soon as possible to start that ball rolling. I would like to see the statewide system of care. I'm only in my 5th year here, but I am telling you, I am sick and tired of everyone talking about how we value primary care, and we have starved the system of care. Took testimony the other day. 50% of all care in the state is delivered in primary care, and they're getting about 5% of the spend. We are starving our system of primary care. And I will tell you, every single person that we had, every facility And I don't mean to call any of you out because I realize that financially it is not doable. Every person who sat in that witness chair, I pulled up the website and I went to their hours. And there are no evening hours. There are very limited Saturday hours. There are no Sunday hours. And from somebody who spent all of last summer sitting in an emergency room, waiting room half the time, we are sending people to the most expensive care because we've starved primary care because they can't even afford to have somebody have expanded hours. They can't afford to pay staff that. I know that. They can't keep the lights on that long. And we have waiting rooms filled with people who don't frankly need to be there. I know that you can't look at someone and tell what's wrong with them. But when I see people come in and you're bringing your 10-year-old because they rolled their ankle playing soccer, I'm sorry, that's not an emergency. That's a call your pediatrician
Wow, go to the express.
or go to Express Care. I mean, we don't even have we have very little outpatient radiology in the state. I don't know if everyone is aware of that. If you need an x-ray, most likely you got to go to a hospital to get that. How do you think you're going to get that ordered? You're going to go to an emergency room. And it's going to cost a lot more than it should cost. So what I would like to see is I would like to see us develop if we're going to be doing a statewide healthcare delivery plan, which frankly, I'm not sure how this is any different. I'm starting to get mad. I'm sorry. I'm getting spicy.
You're not crying now.
You know, which I don't understand is any different than the healthcare resource allocation plan that we already have, which AHS admitted the other day, well, we already are doing HRAP and we know where all the system of care is. Well, okay, then why is it going to take you 2 years to do a statewide plan? And why do you need all this money to do something that you're already doing? I think that this is work that's already being done. I think it's a matter of us saying, you shall do this and you shall do it now because you've had plenty of time to do it before. We also had Act 51, which followed up Act 167, which tasked AHS with coming up with a system of care. And I would like to see that statewide plan driven by, I think Mari said it, primary care, and primary care needs some teeth. Because right now, all I imagine is a bunch of primary care physicians get in a room together and they come up with all these great ideas and then they come outside the room and they say, look, we have these great ideas, and everybody pats them on the head and says, thank you very much, now go away. And that's what I see is what we have now. And I think we need to get them teeth.
Can you help me understand what teeth means? Because that's what we need in here, right? We need, what's the
They're
teeth?
not just advisors, that the statewide plan is collaboratively being developed with primary care, not just a seat at the table to be able to share their concerns, but an actual party to the development of a plan.
Do you think we need outcomes built into the spec?
I think we need outcomes in everything.
Yeah.
I think we need actionable items where this shall be done by this date, and you shall prove that you've done it.
Yeah. Good.
That's what I'd like to see. I'd like to see reference-based pricing, getting us to global financial budgets, and I'd like to see a much stronger basis of primary care in this state and developing a system of primary care. And I will say, and Brian was talking, we have, let's call it a blueprint of what primary care should be. We know what primary care should be. We have a blueprint. The blueprint for health has become essentially a failed financial, but it's not a failed system. It is what all evidence proves we need to have a highly functioning system of primary care in the state. We have taken the blueprint and we have starved the blueprint. And in essence, we've starved primary care. And the less we spend on primary care, the more we end up spending in hospitals.
Can I ask a question?
Yes.
So really appreciate what you're saying about starving the blueprint. I was struck because I reviewed our budget list recently because I was asked a question. And the administration did not support the blueprint in their budget. So it's not only us. I mean, we talk about a system, and that's what you're talking about. I get it. So how do we get people to step up? I mean, you talk about teeth. I'm stuck. How do we get people to step up and do what's needed if even the administration who creates the budget is not supporting their own program? It was very confusing to me.
The Blueprint for Health is housed in the Agency of Human Services, as is the Office of Healthcare Reform.
As is the Department of Mental Health,
Mm-hmm.
which is, largely ignored in this bill. And I understand we want to support primary care before mental health, but I want to say this is a bill about a healthcare system.
I'm
If you don't have
push
mental
back a little bit
wellness-
on that
If
because
you don't have mental wellness, I don't know how you're going to make it primary care.
primary care includes mental health.
Yeah.
In its application at one end of the continuum. It's not the extraordinary needs on the other side of the continuum, but I think it truly addresses mental health and primary care at the lower, less acute end of the spectrum.
Not the way they talk about it at AHS.
Well, I don't know.
Designated agencies are not
Well,
discussed in
the
here, Leslie.
big thing we do though, is as we construct this bill, we add those things in.
I see
Well, we're
Anne
talking
Donahue
about-
has a amendment coming, so I am very much looking forward to that.
So, yeah, okay.
And I've invited Representative Donahue in to come talk to us because Representative Donahue has some amazing ideas, as does Posey. And, when we talk about like the Blueprint for Health, part of the actual blueprint is a system-wide primary mental health care system of care. We just don't fund it.
Well, we do. I think it's worth thinking about what are we going to do with the designated agencies? I mean, they haven't been funded. They've been asking us for money.
That's a failed system if you ever look at one.
Well, that's why it's good to think about what we may do for them, right?
But it depends on what side of the continuum we're talking about when you think about mental health. I mean, once again, the designated agencies do with certain population, primary care, having worked in it forever, did a ton of mental health. It's what we do. So yes, I think supporting primary care does support mental health at that portion of the population. And I don't think we should forget that.
Yeah.
Okay, I'm gonna ask Jen.
Yeah, go ahead.
I just think it's interesting that the premiums that went up so significantly have driven that we're actually doing something about our education bill. And it is the reason that we're doing it is because our taxes went up so much.
But I think we need that level of let's say, engagement, which I don't think we've had.
It was the community, like everybody's taxes went up and
But
that's the
what got
reason.
people's attention, but the underlying reasons of why people's tax, one of them anyway, was this.
Absolutely.
And, we haven't attended to it with that level of urgency and.
Because everyone still gets their health care. They pay a lot for it, but they're.
It's just a totally
But they
different model.
complain about it too.
Absolutely. That's what
I heard a lot
I'm saying.
about it when I was
But it was
campaigning.
the taxes that went up so significantly that really was the outrage that is the reason that we're doing the education bill.
Okay, let's have Jen join us up front. So honestly, I'm like, first of all, it's my first time doing this, everybody, so
Thank you.
I'm like, how on earth am I gonna put this bill together? And how do you eat an elephant one bite at a time. So I figure let's just start at the very beginning. It's a
One
very
step
good
at a
place
time.
to start. And as we go through each section, we can talk around that section. We can argue, we can discuss, we can suggest language changes. We can throw things away, we can add things in. And hopefully in a few days, we can get through this.
We're gonna get through it.
We'll get through it.
We're gonna get through this. I mean, we will because we will, but it's not gonna be fun because when you look around the perimeter, that's the hard part.
Good morning, Jen Carpenter from the Office of Legislative Counsel. I'm putting the bill up on the screen as passed by the Senate. Resolution 26, an act relating to healthcare payment and delivery system reform. And bill that currently stands, it starts with a purpose and goals.
Let's go through the purposes and goals. Honestly, I mean, because I think we actually have purposes and goals that are different than perhaps what the Senate had.
Right, so it starts with the purpose of the act is to promote the transformation of Vermont's healthcare system. And enacting this legislation, the General Assembly intends to advance the following goals. First, improvements in health outcomes, quality of care, and regional access to services. Second, an integrated system of care with robust care coordination and increased investments in primary care, home health care, and long-term care. Third, stabilizing healthcare providers, reducing commercial health insurance premiums, and managing hospital costs based on the total cost of care, beginning with reference-based pricing and continuing on to global hospital budgets, and improving population health and increasing access to health insurance coverage.
Is the purpose of this bill, do we think, really to promote? I'm asking about the word promote.
What would you like to see? Ensure? Shall ensure? I go for shall.
Jen would, oh, right there. It's line 6. The purpose of this act is to promote the transformation. Is that really what we're doing here? We're promoting it? Or are we putting in legislation to ensure it or to?
Transform. Care system.
Is to, I don't know, how does everybody feel about promote?
I don't like
Seems
it.
like a weak word to me.
I think we should, I'm talking about action.
Yeah,
And if you eliminate that, eliminate it, eliminate the, and then put transform instead of transformation.
the purpose of this act is to is the
Michael.
transformation of Vermont's healthcare system?
No.
Transform.
Is to transform
Transform.
Vermont's healthcare system?
Kind of good.
Oh,
It's an active phrase.
Yeah, I want to, I mean, maybe make sure it's not the right word, but I think guarantee, you know, I mean.
I'd be careful about guaranteeing. The same thing as ensuring. I don't think you can.
Right.
is there an action-oriented word that you can think?
That's
Help create a world-class health.
All right, let's move along.
I mean, it may make sense to wait to fix the purpose until you've actually done what you want to do to the bill.
Yeah, that's true.
And we don't necessarily have to have a purpose section either.
I actually think having a purpose is really important in this particular bill, because I think legislative intent is, it sets the tone.
Just promote healthcare system. Vermont's healthcare system.
Well, I don't want to promote it.
I think the
I wanna-
purpose of having promote is that we're promoting it by giving the authority to all of the folks named out in the bill. So I don't know, promote makes sense to me because of that, but I'm also fully in support of just saying the purpose of this act is to transform Vermont's healthcare system. if we can't settle on it, let's move on.
Okay.
Well,
We have a lot of work to
I was
do.
just gonna say about transform Vermont's healthcare system, where other states look to Vermont as a leader. Or something to them.
I mean, but is your goal Vermont focused, or is your goal how Vermont looks to the rest of the country?
Well, if we have a, you know, a
Yeah.
superb system, then it'll automatically
Yeah.
happen. Others will come to Vermont to see the system. I don't know, transform Vermont's healthcare system, I think is the key role.
Leslie? I'm struggling a little bit with transform because it's like, where do you start, where do you end? It seems really big to me. But I'm wondering if we just took out the first sentence at all and just said, in enacting this legislation, the General Assembly intends to do, and then 1 through 4. And that seems kind of
Yeah.
a
Be
statement.
an intent section rather than a purpose.
Yeah, the intent is,
I like that.
What did you say, enhance?
that feels a little vague to me, but, and who gets to say it's enhanced?
Who says we're transformed?
I'm not, yeah, that's why I'd rather take it out. Altogether. That was my thought.
How do you say move along?
No, let's move along.
Purpose of, well, no, I'm saying. The purpose of this act is
That's
move
got
along.
promote, but yes.
Okay. We can move on from this,
There we go.
but I'm just going on record as I don't like the word promote because it seems to me to say we're advertising.
It's
I
too
mean,
passive.
it's passive.
Yeah.
Yes.
It's like we're cheerleaders saying rah, rah,
Rah, rah.
transform instead of we shall transform. Okay,
Before we move on, if you're thinking about. What's that? Before we move on from that section, if you're ready. I think we should add a number 5, that talks about workforce. And protecting our workforce.
actually, well, let's talk about 1, 2, 3, and 4.
Okay.
Anyone have any problems with 1, 2? Three.
Like these. I mean, I think they speak to the elements of a modern healthcare system and the things that healthcare reform around the country is striving for. I don't think we took testimony from any of the providers in the system on this specifically, but from what I know about healthcare reform, all of these things collectively get at the quadruple aim. I'm looking at the sideline here.
All right.
That sounds off on my phone, sorry. I don't know if it's this section that would be the appropriate place, but I also think we need stronger language in there about evaluating effectiveness, and holding ourselves and state government accountable with we're really clear ways of measuring
I like that.
Love it.
goals.
And again,
So the purpose is to hold accountability.
To create accountability. Create standardized accountability measures. Something about
Let's look at PPQs.
on a regular basis. Sort of metrics.
I like that. I see Jen sort of like writing.
Making
Making notes.
notes.
We can wordsmith it later.
Yeah.
I mean, there are many sections at the end of the bill, which essentially are like, you will be accountable. So we should put that in the purpose that we are holding you to. And that the purpose of this bill is to have accountability.
Yeah.
I like that. I have a question about for improving population health and increasing access to health insurance coverage. Is there anything in this bill that deals with increasing health insurance coverage?
I don't know that there is specifically. I think it may be more in the realm of making it more affordable by bringing down the costs of care.
Let me say something to that effect.
I mean, you could get rid of it. I mean, you can, you can change it however you want. These were added toward the end of the trust.
Would anybody be amenable to taking population health and putting it into number one? Improvements in health outcomes, comma, population health, comma, quality of care,
Yeah.
comma, and regional access to services, and just getting rid of 4, or making number 4 accountability.
Yeah.
What about increasing access to health insurance? Leave that out?
Not sure necessarily anything specific we're doing increases access. I mean, we do have the reducing commercial health insurance premiums.
AHS already measures that. I know it's one of their scorecards.
And we want to increase access to healthcare, and part of which might include increased access to insurance, but it might not.
I also think one of the issues that you hear about a lot is the underinsured. So people may have access to coverage, but they can't actually afford to use it.
Yeah.
It may not be a good reflection of what you're looking to do.
Yeah. To me, coverage just seems, do you have it or do you not? And I think the stabilizing healthcare providers, reducing commercial health insurance premiums. I think that kind of gets to
That's the
what we,
premiums piece. Yep.
How are we going to actually reduce? I mean, how do we do something that we don't know?
talking about commercial health insurance premiums.
No.
Well, I think one thing that we've heard of all the testimony is that if we want to reduce commercial health insurance premiums, we need to reduce hospital costs.
Well, yeah.
And pricing.
I look at that as controlling the premiums, not maybe reducing them all.
Well,
Reducing the rate of increase.
I think at $3,900 a month currently, do we think we want to reduce?
I'm not arguing that. I'm asking a question.
So it's not gonna reduce it, it's gonna reduce the huge increase every year. So it's not gonna go down.
So maybe controlling is a word
Yeah.
that gives you, that was Representative McFawn's word, that may be a word that gives you more flexibility in what that looks like.
I like controlling.
Yeah,
Where would you put that?
Instead of reducing.
Instead of reducing, controlling.
We're gonna do that. It's the reference. Global.
By managing hospital costs based on the total cost of care, beginning with reference-based pricing and continuing on to global hospital budgets. Hey.
What does managing mean? Sorry.
Well, I was gonna ask everybody, we've had this long discussion. Every single person seems to have a different definition of what a global hospital budget is. Should that say a global hospital payment? Or should it say a budget? I mean, a budget is effectively what they do right now by
Right.
saying, here's how much you're allowed to net patient revenue.
Wasn't there a question of not using that metric, net patient revenue? I think there was.
I know, but isn't that effectively what a global hospital budget is? So do we want
I
to,
think
do
you-
we want to get specific about what people actually mean by that? Because
Yeah.
it seems to mean something different by everyone.
I think you're right, Alyssa.
I think maybe we define it where it actually gets used later in the bill.
Yeah.
All right, let's do that.
To me, a payment is different than a budget.
Global payment or a global budget.
If it's a budget, it includes all the money that the hospital gets. They just don't get the, $10 a year, they get donations and everything else. And that's how they build their budget.
I'd like to see managing not be that. I'd like to say reduce. Because once again, I reduce hospital costs because I'm still thinking about how we shift from hospital, where the hospital takes so much of our spend to how do we get it to primary care?
So I think this is more describing the mechanisms that managing it based
By
on,
using those other things.
right, based on total cost of care.
Got it. Which means we're believing that that will do it. Which is a whole nother question.
Or should it be reducing it using these methods?
Yeah, that's what
I mean, ultimately, that's what we're trying to do is we're reducing it.
Yeah, I mean, that would be the
Of
goal
course, this will be in forever.
or not.
Let's think on
I'd
managing.
rather have reducing than managing.
I don't think reducing works without other changes to the phrase, which is fine, but I don't think it makes sense to say reducing hospital costs based on total cost of care.
What do you think it should say?
I think you could say reducing hospital costs, something like through the use of reference-based pricing and global hospital budgets, but
That's fine.
but
So
that gets rid of the total cost of care concept. And I don't know if that's what people want or not.
So my only concern with putting reducing hospital costs is that, while that is our goal to reduce hospital costs, it's just hospital costs are going to go up, but are we reducing it to a rate where, right? I mean, we have inflation, we have medical inflation, they're going to go up year over year. So I would be concerned about putting in reducing there.
I think you're right. Which I forgot this will be here forever.
Right.
It may not always be able to reduce. The more I'm kind of looking at
I
managing.
think these are goals.
Yeah, these are goals.
Yeah, oh, we're just on.
You didn't miss much. We're still on the
Page
goals.
one.
All right, should we move on to
I
some
think
of
we should move
the,
on.
Well, I still want to add a 5 about work.
Oh,
Or
so
talk
we're
about.
gonna do accountability. We're gonna add
yeah, is number 4.
accountability is 4. And then we're going to, we have stabilizing healthcare providers. Does that get to your workforce?
It's more about moral injury, in protecting our workforce, within the system. About moral injury, improve the dignity of the workforce, because we need people to stay and we need people to come. So that's what I was thinking.
I think this might be one of those times where our goals conflict with one another.
How do you mean?
I mentioned this in that this is not going to be pretty. Right sizing our system,
And have an impact.
it's gonna have an impact. We know it is. And if we put in there that one of our goals is for it not to have an impact on our workforce, I think that may be impossible to achieve.
Well, I hate the idea of giving up on that idea. I mean, it's one of our principles, right? Supporting and valuing a healthcare workforce, they aim at fight to fair meet the ongoing needs of people in Vermont.
Yeah.
That's what I'm thinking about.
It could be something like support workforce, healthcare workforce during transition.
Do we have anything in the bill that supports workforce during transition.
Well, there's something about collecting data about the workforce, adding to the Green Mountain Care Board's brief to have hospitals talk about their workforce. How many here, how many there, you know, that kind of thing. So there is that somewhere in there. I could find it, but it's there.
In terms of protection, we have, I don't know where it is now, but we have a protection bill.
Yeah, but that's not necessarily through the transformation. So it's just something I think we need to protect her. I mean, protect, what does protect mean?
Right. I was just about to ask you.
Yeah, yeah, and I think that's the right question, but it's also, how do we get people to stay? How do we get people to come? How do we create a system that this is the best place in the country? Who said that to, Woody, you said this, best place in the country to work. So everyone comes here. So
Well, maybe that's what you want to say,
Yeah,
rather than,
enhancing the workforce experience in the system of care,
Yes, sir.
something.
you know,
acknowledging that.
I mean, I think we've talked in past legislation about recruiting and retaining high quality
Mhm.
healthcare professionals, so.
Creating an
something-
environment
Right,
so
yep.
we can retain
Yep.
and get.
I mean, Mari,
Also like to add something without using a specific word, promote fair access to services as defined in 18 BSA. You want to say promote? Yes, I guess it's 251. Well, I can send you the
I'm not clear on just the concept.
equity.
Oh, okay.
should that be in the regional access to services, and we should include something about equitable access of services? Which,
Access to all.
Fair access to services, I think is. Yeah, for all Vermonters, yeah.
I worry about the use of the word fair because it sounds like it's in the not as good as good. Fair, like, you know,
Yeah.
moderate,
A different version of it.
right?
it also means that if somebody
Yeah, but I-
is 5 miles from a cardiologist and somebody is 30 miles from a cardiologist, we cannot ensure that everybody's gonna get equitable 5 miles from a cardiologist.
30 miles isn't bad.
Well, I know.
I mean,
I'm saying if we're gonna put in that everyone has equitable access, we need to think about what does access even mean? And what does
What are we trying
equitable,
to-
what are we trying to
What
get?
are we trying to get at with equitable without using the word?
Make a suggestion?
Yes.
I think it might be helpful to go through each section to see how we change it, to then come back to the goals, maybe?
I should mention.
Oh, okay.
Coming back to it, yeah.
Let's table it as we go through. All right, can we take a break? We've been at this for an hour and 40 minutes.
We only got the goals.
Let's come back
That's all
in.
right. It's a big deal.
It is a big deal. Yes.
Yeah, it's a big deal. We got a lot of stuff out. And I got a page full of things that people, I think that we actually all have a lot more agreement than differences on what we want to see. Okay,